Good morning. So I'll be discussing about the management of deep bite malocclusion. Deep bite is one of the most frequently seen malocclusion in orthodontic patient, which is also difficult to treat successfully. It is considered as one of the most damaging type of malocclusion due to the fact that it has traumatic effects on the health of the masticatory apparatus and also on the dentition. So Graver has defined deep bite as a condition of excessive overbite wherein the vertical measurement between the maxillary and mandibular incisal margin is excessive when a mandible is brought into habitual or centric occlusion. So this is the picture of a deep bite malocclusion where you can see that there is increased overbite. Also there is extrusion of the upper anterior segments. So if we were to classify deep bite malocclusion, it can be broadly classified as incomplete, complete, and dental and skeletal deep bite. So first coming to incomplete deep bite, it is a condition wherein an incisor relationship in which the lower incisor fails to occlude with either the upper incisor or the mucosa of the palate when the teeth are occluded. So this is a type of deep bite wherein the lower incisor does not occlude with either the upper incisor or the mucosa of the palate. Next, coming to complete deep bite. In this type, the incisor relationship will be such that the lower incisor contacts the palatal surface of the upper incisor or the palatal tissue. So there will be some kind of contact happening between the lower incisor and either the palatal tissue or the upper, palatal surface of the upper incisor when the teeth are brought into centric occlusion. So coming to dental deep bite. So it's a type of deep bite which is confined to the dentition where there is extrusion of the angles and intrusion of the molars. It is often seen in angles class 2 division 2 malocclusion. So what are some of the characteristic clinical features of dental deep bite? So there will be extraoral features and intraoral features. So in extraorally, we can see that there will be a decreased lower facial height of the patient. Intraorally, we can see many features such as increased overbite, decreased overjet, extruded maxillary anteriors and intruded maxillary posteriors. And also due to this, there will be an increased susceptibility to foot impaction in the lower anterior region and resultant gingivitis will be present in that area. So when we see the cephalometric findings, we can see that there will be an increased interincisor angle for a dental deep bite. Coming to skeletal deep bite. Usually the skeletal deep bite will be of more of genetic in origin caused by upward and forward rotation of the mandible. Also, it can be termed as the counterclockwise rotation of the mandible. It can also be caused by clockwise rotation of the maxilla or a combination of both. Skeletal deep bites are usually seen in angles skeletal class 2 division 2 malocclusions. What are the clinical features of a skeletal deep bite patient? So extraorally, there will be a decreased lower facial height. Intraorally, as previously said, there will be an increased overbite, decreased overjet, and increased risk of gingivitis in the mandibular anterior region. So these features will be similar for dental deep bite also. In cephalometric findings, we can see that there will be an increased height of the ramus of the mandible. There will be a decreased FMA angle and upward and forward rotation of the mandible. So how do we diagnose a deep bite malocclusion? Thorough extraoral and intraoral examination of the patient should be done, and all the history should be taken properly. And if the patient is having any oral habits, that also has to be noted down. So we can use various diagnostic methods such as clinical examination and by virtue of study models to evaluate the extent and the severity of the deep bite. And when it comes to lateral cephalograms, we can evaluate if the height of the ramus is increased or not. And also interincisor angle, increase in interincisor angle, and Frankfurt mandibular plane angle. All this can be evaluated by virtue of lateral cephalograms. So how do we treat a deep bite? So there are various modalities for treatment of a deep bite. Mainly there is maxillary anterior intrusion, maxillary posterior extrusion, mandibular anterior intrusion, mandibular posterior intrusion, or a combination of all these things. So initially light forces has to be used for incisor intrusion, that is maxillary incisor intrusion, whereas we can use heavier forces for extrusion of the posteriors. So deep bite can also be treated by using certain removable myofunctional or fixed orthodontic appliances. So coming to removable orthodontic appliances, we have an anterior bite plane appliances which can be used in conjugation with a fixed mechanotherapy. This is kind of a modified version of Hawley's removable appliances with the following feature, such as presence of Adams class on molars, which aid in retention of the bite plane, and we have a labial core which prevents a maxillary anterior proclination, and the bite plane thickness should be around 1.5 to 2 mm, not be more than that. Next, we have the flat anterior bite plane. It is usually made up of acrylic base material behind the maxillary incisors, so that the mandibular incisor touches the bite plane before the buccal teeth come into occlusion. So it can be used to reduce the incisor overbite in angles class 2 division 2 and angles class 1 malocclusion also. It basically induces an extrusion of the upper and lower posteriors by disoccluding them and thereby bringing about the reduction of the incisor overbite. So next, coming to inclined anterior bite plane. So inclined anterior bite plane is usually used for correction of the deep bite in angles class 2 division 1 malocclusion. So it basically induces a forward mandibular posture and reciprocal backward forces exerted on the maxillary teeth due to masticatory forces and extrusion of the lower posteriors. So we can take use of various myofunctional appliances too for correction of a deep bite malocclusion. Some of the myofunctional appliances include activator, binator, and Frankel appliances. So next, coming to fixed orthodontic appliances. In fixed orthodontic appliances, we can take use of certain intrusion and utility arches, and they can be used to bring about correction of deep bites by intruding the incisor, upper and lower incisors. So it is mainly indicated in patients with excessive maxillary incisor visibility at rest or when during smile, or otherwise known as gummy smile. If the patient is seen to be having a gummy smile, we can try intruding the maxillary incisor by virtue of intrusion or utility arches. So what are utility arches? They are arch wires used with along with fixed orthodontic appliances. They are fabricated in such a way that they usually bypass the premolar region and they are engaged on the incisors and also on the molar tooth. So they can be basically activated by giving a small V bend in the buccal segment of the wire mesial to the molar, so as to generate an intrusive force on the incisors. So we have other treatment modalities that can be made use of, such as arch wires with reverse curve of P and usage of certain anchorage bend in the arch wire. Thank you.